Assalamu alaikum wa rahmatullah. Good evening to everybody. I'm Yousef Alsaleh, immediate past president of the Gulf Association of Endocrinology and Diabetes. Would like to welcome you all to this event organized by Gulf Association of Endocrinology and Diabetes. As you know, the Gulf, the American Association of Clinical Endocrinologists has dissolved its chapters both locally and internationally. And in the Gulf, we changed our name from Gulf chapter to Gulf Association of Endocrinology and Diabetes. We are still committed to serving the endocrine practice in all the Gulf states and welcome you all to join us as members and as speakers and chairs in our various activities. I would like also to alert you to our journal, the Journal of Diabetes and Endocrine Practice. Please submit your papers to that journal. Tonight we're going to have a very interesting topic. We are all aware about X-linked hypophosphatemic rickets, especially with the advent of new therapy for this disease. We used to miss many of these patients and the complications are so enormous. And I would like to thank KASCH, the sponsors of this activity, Amber, the organizers, and our two speakers who are going to address us on this important subject tonight. So since the advent of burosumab as treatment for this disease, the interest and the focus has become more and more pronounced. Without any further delay, I would like also before starting the meeting to alert you to please visit our association webpage, gulfgaid.info. And also you can join us in various social media like Facebook, Twitter, and you can visit our YouTube account and you can see all the previous presentations and also the current one once you register to view all these topics delivered so far by GAED in the past and also in the future. All of our activities will be posted on these social media, especially YouTube and the web page. We'll start with our first speaker, Dr. Fahd Aljuraibah. Fahd is a colleague, and it happens that he works in the same institution that I work in Riyadh, King Abdullah Specialized Children's Hospital. Fahd has graduated from King Saud University in Riyadh back in 2007. And he finished two boards, Saudi Board of Pediatric and the Arab Board of Pediatric. Subsequently, in 2017, he finished 2 years of training in pediatric endocrinology and metabolism in the kingdom. And this is a program operated by the Saudi Commission for Health Specialties. In June 2018, he joined the Royal Hospital for Children in Glasgow, United Kingdom, where he did clinical fellowship in pediatric endocrinology, focusing on disorders of sexual differentiation and complex bone disorders. And this is the reason that Fahd has been invited to this meeting to address us on this important topic. He has various sort of publications in different topics, aspects of pediatric endocrinology, and he has received several awards because of his great academic achievements. Fahd is going to address us on the progressive nature of X-linked hypophosphatemic rickets from pediatric to adult. The stage is yours, Dr. Fahd Aljuraibah.
Assalamu alaikum wa rahmatullahi wa barakatuh, and good evening, everyone. Thank you very much, Dr. Yousef Saleh, for this kind introduction, and thank you very much for the organizing committee of GAED for inviting me and giving me the chance to participate in the part of the webinar series, which is adding too much to the community and to the region in terms of education and improving the clinical knowledge of the region and in improving also the practice. So what I'm going to talk about, inshallah, in the next 30 minutes is about the progressive nature of XLH, which is from the childhood to adulthood. And this is my declaration and disclosure. And in this, inshallah, lecture, I'm going to talk And I'll take you just to the basic and looking at the difference between rickets and osteomalacia and some basic in the bone structures. Then they offer a few of X-linked hypophosphatemic ricket disease, including its clinical manifestation and the management, which is conventional. And also we'll talk about the brusumab, which is as Dr. Yousef said, it's one of the new medications which has been introduced recently as part of the management of XLH. So we'll talk about it, inshallah. Then we'll talk about the outcome of the disease in adult, and I'll conclude with one of the child that is part of other patients who have been starting brusumab in our institution. Just I will present one of the patient which was started immediately on brusumab, and she wasn't treated with conventional therapy before. So knowing the difference between the rickets and osteomalacia is very important. As you know, that the rickets and osteomalacia, both of them are a bone disease that's associated with decrease in the mineral part of the bone, which is calcium and or phosphate in the blood. But in the rickets, it's targeting or affecting the growth plate, which is the cartilage. So it should happen only in the growing child. So it shouldn't happen in adult because it's already the growth plate, it's already fused. So it's happening in the cartilage of the growth plate. That will lead to widening and delay in mineralization of the growth plate in the bone. That will lead to the sign of rickets, which is usually happen in the area of growing and the rapidly growing bone that's in the wrist and also in the ankle and also the area. On the other hand, osteomalacia, it's affecting also, it has the same background, which is a bone disease that's associated with decrease in serum calcium and also or phosphate level that will lead to delay in or decrease in the mineralization of the osteoid and which is the unmineralized bone matrix. So this will lead to a very weak bone and also a tendency to fracture. So to understand this very well, let us go back and to the basic and to discuss the structure of the bone. So there are two types actually of bone, which is a compact bone, and it is the most or accounts for 80% of the bone in the body, and each bone has two types, the compact and the other is the spongy bone, which is account for 20% of the whole body, but it has very high surface area because it's organized in a network like a honeycomb. So it's have a larger surface area compared to the compact bone. The compact bones give the bone its smooth surface and also it protects the internal organ. If we have, if we look at in the hyper field of the compact bone, you will find these cylindrical structures called osteon, which composed of a multiple concentric lamellae, which is composed of bone cell, basically the osteocyte and also osteoblast, and also the bone matrix. Looking at the bone matrix, 30% of the bone matrix is an organic part, and which is primarily composed of type 1 collagen fiber, which give the bone the elasticity and also the resistance to fracture. And 70% of the matrix composed of inorganic part, which is the mineral part, which is calcium and phosphate, where they complex to each other and cause or form a hydroxyapatite that is attached to the collagen fiber to form the inorganic part of the bone matrix. What we are talking about in rickets and also osteomalacia is the mineral part of the bone, which is the inorganic part of the bone. So there is a defect in the mineral component of the bone that will lead to osteomalacia or to rickets in children. So this is how osteomalacia seen in the under microscope. So this is a normal bone biopsy. So looking at the green color, it's indicate a mineralized bone matrix, and the red color, and as you can see here in the arrow, the red color is indicate an osteoid, which is unmineralized bone matrix. So there is, if you compare this to the B slide, which is taken for a patient with X-linked hypophosphatemic rickets, you will appreciate the larger number of the red color, which indicate a poor mineralization and also a reduced in the trabeculi of the bone. So there is a poor mineralization in patient with X-linked hypophosphatemic rickets. For rickets, so if you look at to understand also the rickets, how the clinical manifestation of rickets happen, you have to understand the the structure of the growth plate. The growth plate usually is located between the epiphysis and the metaphysis, and composed of 3 zones, which is the resting zone and proliferative zone, and also hypertrophic zone. The premature chondrocyte, which is adjacent to the epiphysis, it goes through a sequence of maturation. So it will develop, the chondrocyte will be developed, mature into a cartilage cell, or the cartilage cell will be matured to a chondrocyte that will be hypertrophied, and at the terminal undifferentiated hypertrophic chondrocyte will undergo apoptosis, and then it will be invaded by the vessels, and also the primary spongiosum will be formed, and the newborn formation, or a newborn will be formed, and the child will get longer. So it has been studied what is the possible, or what is the exact mechanism of the hypertrophic chondrocyte apoptosis, and it has been shown that the phosphate is one of the important ions that is responsible for apoptosis of the terminally differentiated hypertrophic chondrocyte. So if there is a phosphate deficiency, this hypertrophic chondrocyte, which is arranged in a columnar fashion, it will be accumulated, and it will lose its shape, and will be accumulated here, and it will lead to widening of the growth plate. So as you can see here, this is a normal growth plate. This is the hypertrophic chondrocyte, which is really arranged in a longitudinal manner. But if you look at the patient with rickets, you can see that the hypertrophic chondrocyte or the organization of the hypertrophic chondrocyte, it's rearranged. That will lead to the clinical sign of rickets. So there are 2 types of rickets and osteomalacia, which is the calciopenic rickets and the phosphopenic rickets. The calciopenic rickets, it's actually what we are talking about, the primary or the problems in the dietary calcium. So there will be a calcium deficiency that's related either to a calcium deficiency from the intake of malabsorption, or most commonly related to vitamin D deficiency, or part of an inherited vitamin D dependent or inherited types of vitamin D deficiency. And this decrease in calcium level will lead to increase in the parathyroid hormone level, and the parathyroid hormone level will lead to increased phosphate wasting in the urine. But on the other hand, the phosphopenic rickets, the defect in the phosphate itself, so there will be no problem with the parathyroid hormone, but there is a problem in handling phosphate in the body, so there will be an excessive phosphate wasting in the kidney, because the primary defect in the renal tubular or proximal renal tubules, which is the primary site for phosphate absorption. And there are many diseases that can lead to hypophosphatemic rickets, and the most common one, the disease that we are talking about, is the X-linked dominant hypophosphatemic rickets. So both of them, they have the same problems, which is the renal phosphate wasting that will lead to hypophosphatemia, that will lead to impaired apoptosis of a terminally differentiated chondrocyte, and will lead to rickets, and in adult, also in pediatric, if it's in the growth in the osteoid, it will lead to mineralization of the bone matrix that will lead to osteomalacia. So if you would like to approach or to categorize the causes of phosphatopenia or phosphopenia, there are 2 major categories, which is the non-hyperphosphaturia and the hyperphosphaturia. The non-hyperphosphaturia, basically, we are talking about the decrease in phosphate intake, which is uncommon because most of the food are enriched with a good amount of phosphate. But there are specific group of patients that are vulnerable to phosphate deficiency, like patients with in pediatric, like those patients with a premature or low birth weight, and they are TBN, which lead to decrease in multiple minerals, including phosphate, or patients with malabsorptive disorders, or taking medication that interfere with phosphate absorption. And the other important types of phosphopenia is the hyperphosphaturic, and the most common one is the hyperparathyroidism, which is usually related to a calciopenic problems and primarily vitamin D deficiency, or it can be due to an FGF23, which is a phosphatemia that's regulating phosphate in the body. And what we are talking here is basically about the X-linked hypophosphatemic rickets and other disorders, and also there are other acquired disorders that we'll talk about it in the next slide, and the non-FGF23 mediated rickets. And basically here we are talking about a primary defect in the proximal renal tubules. So it could be part of a syndrome like Fanconi syndrome or a Dent disease, where there is a proximal tubulopathy, which lead to a multiple or the renal tubular acidosis. So there will be a leak or loss of bicarb and also other minerals and other electrolytes like sodium, potassium, and also including the phosphate, or it's part or isolated problem like in a patient with hereditary hypophosphatemic rickets with hypercalciuria, where there is a mutation in the phosphate or sodium phosphate cotransporter 2A and 2C. So this is the 23 or the FGF23 mediated hypophosphatemic rickets. There is congenital causes and also acquired causes. And the most common cause of the FGF23 mediated rickets is the X-linked hypophosphatemic rickets, which is caused by a mutation in FIX gene. And to understand this very well, the fibroblast growth factor, it's expressed really in many tissue, but primarily it's expressed in the osteocyte and also osteoblast, and its regulation in the body, it's regulated by many transcriptive factors, including FIX gene. So the FGF23, the main function of the FGF23 is to regulate the phosphate in the body. So it's like the parathyroid hormone for the calcium, but it doesn't have the same action. It's really hate the phosphate. So if the phosphate is increased, the FGF23 will be increased. That will lead to excrete the phosphate out of the body, and also it will decrease the 1-alpha hydroxylase, and that will lead to decrease 1,25-dihydroxyvitamin D. So it will decrease the intestinal absorption of phosphate. So if there is any increase in FGF23, which is pathological, if there is any pathology that causes an increase in FGF23, this will lead to a decrease in sodium phosphate cotransporter in the proximal renal tubule that will lead to decreased phosphate reabsorption in the proximal renal tubules, and also it will downregulate the 1-alpha hydroxylase in the proximal renal tubule that will lead to decreased converting or activation of the 25-hydroxyvitamin D, and also it's increased the expression of 24-hydroxylase. So the net result will be decreased. There will be a decrease in the active form of the vitamin D that will lead to decreased intestinal absorption of phosphate, and the net result will be hypophosphatemia. And this is how the FGF23 mediated or the FGF23 lead to hypophosphatemia. So in the X-linked hypophosphatemic rickets, there will be a mutation in FIX gene. The mechanism why the FIX gene it's lead to increase of in the FGF23 exhibition is not really well understood, but it has been postulated that it's involved in the enzyme that's responsible for degradation of the FGF23. So if there is a mutation in FIX gene, this will lead to an increased exhibition of fibroblast growth factor 23, and this will lead to an increased renal phosphate wasting and also decrease in 125-dihydroxyvitamin D that will lead to decreased GI absorption of phosphate. That will lead to a low serum phosphate, then a clinical manifestation of X-linked hypophosphatemic rickets. So in pediatric, usually those patients, they will have a delayed and also a disproportionate growth. Usually they tend to have a lower, severe bowing of the lower extremity. So most of the clinical manifestation appear in the lower limb compared to the upper limb. So they will have a disproportionate short stature. Usually their sitting height is almost normal, but their standing height will be low, and that's because of the short lower limb. And 40% of them they may present with craniosynostosis, especially sagittal craniosynostosis, with or without symptoms, and also with the clinical manifestation of rickets. And also with all of these, they may have a delay in motor development and gait abnormalities. And also there is another clinical manifestation that happen in pediatric, also in adults. They usually end up with a short stature, and they will have a deformity in their limbs, and they have a tendency of tooth abscesses, and that's why, because that's happened because of the problem in the dental mineralization and also in enlargement of the pulp chamber that will lead to a frequent tooth abscesses. And also they do have osteomalacia, bone and joint pain, and they may have chiari malformation, which is under-recognized because most of most of the patients they will not undergo an MRI, and if there is no MRI, the chiari malformation will be missed. The disease usually is extended to the adult, and that lead to a frequent fracture called pseudo-fractures, which is painful, and also some of the degenerative diseases like an early osteoarthritis, and also extra-osseous calcification that's like enthesopathies, and which is really painful, and also they may develop a hearing loss that may be because of the compressive either neurological because of the compression in the by the skull, and also they do have a disability that impact their quality of life. And this is the biochemical feature of X-linked hypophosphatemic rickets. As we say, it's the primary problem is the decrease in the serum phosphate, and they don't have any problem with the parathyroid hormone. Usually it is normal or slightly high, but usually it is normal. And their TMB-GFR, which is the tubular maximal reabsorption of phosphate in relation to GFR, is decreased, which is also interpreted as a high urine phosphate, and usually their alkaline phosphatase is high, but it's not that high compared to the nutritional rickets, and their calcium will be normal. Vitamin D should be normal, but we are an area of endemic deficiency of vitamin D, so sometimes you will find the deficiency of vitamin D that you correct it and still the manifestation persists, and they usually do have a normal or decreased level of active vitamin D, and we can say that it should be interpreted as inappropriately normal in a setting of hypophosphatemia, and usually they do have high or inappropriately normal FGF23, because with the low phosphate, the FGF23 should be suppressed. And this is how to compare the XLH from the nutritional vitamin D deficiency. Usually the alkaline phosphatase is very high in the calciumenic rickets, and usually the parathyroid, the calcium will be sometime in the lower side of normal or low in nutritional rickets, and the parathyroid hormone tend to be very high or higher in the nutritional rickets, and their FGF23 will be normal or low in the calciumenic rickets compared to the XLH. So how to treat those patients? Usually the treatment, just to understand, once it has been treated with a conventional therapy since 1980, and the conventional therapy basically it's based on the pathogenesis of the disease. So as we said before, the FGF23 will be increased, and that will lead to high urine phosphate, and that will lead also to decrease in the active vitamin D, which will lead to low serum phosphate that will lead to rickets and osteomalacia. So basically, the treatment is to replace the excessive urine phosphate leak by giving an oral phosphate. But the problem with the oral phosphate, it will be rapidly absorbed and rapidly excreted in the urine. So this is require frequent dosing in order to improve the phosphate in the body, in order to improve the mineralization in the bone, and this will lead to healing of rickets and osteomalacia, which is unfortunately not happening in most of the patients. And the other points, because of the decrease in the active vitamin D, you have to give vitamin D, which will improve the phosphate also by increasing the phosphate absorption in the gut, and also to counteract the hyperparathyroidism, which usually happen due to the frequent dosing of the phosphate. So you have to balance. You have to balance the treatment based on. So if you give too much of phosphate, in order to improve the clinical manifestation, the side effects sometimes would appear, which include the hyperparathyroidism that may be so severe to cause tertiary hyperparathyroidism that might need some time parathyroidectomy. So this is the recommendation and how to treat and to follow those patients and children. So usually we are giving them phosphate 20 to 60 milligram per kg per day, which is 4 to 6 times per day, and also alpha calcidol 1 to 2 mites once per day. We have usually we are seeing them so frequently in the beginning just to follow their clinical performance and clinical improvement and the clinical outcome by looking at their growth parameters, skeletal deformities, and the teeth, and also doing some blood tests to aiming to normalize the alkaline phosphatase and not to increase the parathyroid hormone, and also to do a urine for calcium creatinine ratio in order to follow for to prevent or to adjust the dose of the alpha calcidol, because too much if you give too much alpha calcidol, this will lead to hypercalciuria and it will lead to nephrocalcinosis. And that's why renal ultrasound should be done in annual basis, and the dental follow-up should be done by an expert dentist, that they looked at the dental abscesses and the manifestation, or the dental manifestation in XLH. And this is the table that showed the dosing from infancy to the adulthood to the menopause also. You can see the phosphate tend to be high at the beginning, and it's going to be low in adult. And actually in adult, there is a controversy in regard of the treatment, but usually if there is no symptoms, most of the recommendation just not to do anything. But if the patient is symptomatic, you may need to treat him as also in the pediatric age group. And so this is one of the good study that's looked at the outcome of adult patients with X-linked hypophosphatemic rickets who've been treated with conventional therapy, and has been published in 2017 by Douglas and his colleague. And they studied 59 adults with XLH who has been treated with active vitamin D and also vitamin O and also phosphate. And they found that the orthopedic involvement that requiring surgical intervention like osteotomy was so frequent, and they found also that the joint replacement and laminectomy was observed in those older than 40 years. And also they found that the dental diseases was so frequent. With some of them, they do have frequent abscesses and also dental caries, and it has been found in almost 60%. And in 40%, they do have nephrocalcinosis, and 14% they do have a hearing impairment. So it is really devastating disease. And I was trying to look at most of the adult paper, but unfortunately, there is no much data in adult. And this is one of the systematic review that looked at all the study in adult that looked that looked at the adult study, whom studying the long-term outcome of XLH in adult. And most of the study were based on, or most of the data which was collected in this paper, it was based on a poster presentation in conferences and just case reports or case series with minimal amounts of numbers of original articles in adult, indicating that there is paucity of data in adult, or looking at the long-term outcome of the disease in adult population. And by collecting all the data, they found that there are frequent dental abscesses, and also there is the extra-osseous calcification, including nephrocalcinosis and enthesopathy and others. Manifestation was also frequent, and also the hearing loss was one of the complication, or one of the major problems also in the adult. And also they tend to have some degenerative diseases and also bone problems like pseudofractures and osteomalacia, bone pain. And all of these lead to a considerable disease burden, and also it affects their the quality of life. So based on all of these, based on in our region, we try to do something just to collect about the impact of the disease in our region. So we have conducted in the last year a survey, and which was distributed to the region through the Arab Society of Pediatric Endocrinology and Metabolism. And we're part of our aim in that survey was to look at the current practice in treating patients with XLH, and also to evaluate the knowledge and the practice of the pediatric endocrinologist, and to look at the outcome of the disease, and also to ask them about the challenge. And then we found that the challenge that they face with XLH, they do have a poor compliance to the patient. They are not compliant to the treatment, and some of the symptoms, they don't have the access to the medication, especially the phosphate. And there was most of the patient end up with a shorter stature, and the problem that most of the patient they have the persistent skeletal deformities, which needs surgery in the adulthood. And 25% of the respondent, 25% of the the patient, they do have nephrocalcinosis, and also the hyperparathyroidism was one of the frequent side effects that has been observed by the clinician, and to the point that 5 patients were in senior acid, and the parathyroidectomy was considered. So it's really devastating, and because of this, there was many efforts to develop a new medication that may improve the outcome. So in 2014, the initial clinical trial was in mice, looking at the anti-FGF23. So looking at the therapy that targeting the FGF23. So the Purosumab has been introduced recently as a treatment of X-linked hypophosphatemic rickets, and it was recently approved to be a treatment option for X-linked hypophosphatemic rickets. And it is a monoclonal antibodies that targeting FGF23. So if there is a high FGF23 and you are giving an Purosumab, the Purosumab will attach to the FGF23. That will lead to decrease in the effect of the FGF23 in the kidney. That will lead to improvement in the phosphate reabsorption in the kidney, and also improvement in phosphate absorption in the gut. So it was approved by FDA to adult and also pediatrics, and also in EMA, and recently it has been approved in our country as a treatment for adult and also pediatric more than 1 year of age. And this is the approval was based on a clinical trial, 3 clinical trials, but I will present one of them. This is a randomized controlled trial. They compared Purosumab versus a conventional therapy in children between 1 to 12 years of age. 29 of them, they received Purosumab every 2 weeks, and 32 patients, they were randomized to the conventional therapy. And they looked at the outcome after 40 and 64 weeks, and they looked at the radiological improvement by looking at the global impression of change, the improvement in the radiological manifestation, and the blue color is the Purosumab. So after 40 weeks of treatment, there is a significant improvement in the radiological changes, which was persist, even improved a little bit after 64 of treatment. And also the severity of rickets has been improved. Has been improved in Purosumab compared to the conventional therapy. And this graph showed the level of alkaline phosphatase. They started at around most of the patients. The mean alkaline phosphatase was around 500, and there is an improvement in the Purosumab compared to the conventional therapy, which was significant, which was statistically significant, which indicate that in the short term, the Purosumab it's really superior over the conventional therapy. So before I conclude, I would like to present one of the patients that has been started in Purosumab. And I do have almost 8 patients in Purosumab, but this is one of the patients which has been started from the beginning on Purosumab. She was seen at the age of 34 months in my clinic, and she had a problem of progressive bowing of lip, where she was diagnosed initially as a Blonde disease, and Blonde disease is one of the orthopedic diseases that need a really correction or surgical correction. But because there is a link between us and also orthopedic, we chat together about the patient, and they refer him to me, and we found that she's short, and also she has a macrocephaly, and she has abnormal head shape and overriding sagittal suture by clinical examination, and also she had a clinical sign of rickets. And this is the biochemical result. She had a high alkaline phosphatase with low phosphate, and she had a normal parathyroid hormone level, and she had normal vitamin D and normal 125 dihydroxyvitamin D. She had excessive phosphate leak, and also high FGF23, and this is her skeletal X-ray, which you can see a bowing of the lower limb, and also clear manifestation of rickets where there is splaying and also irregular sclerosis or calcification, of the growth plate. So this is one of the algorithms that I like it. If you face a patient with rickets or osteomalacia, just capture it and go through it. This is how to approach patient biochemically. If you find a patient that you suspect rickets or osteomalacia, and you find the low phosphate, just go through this algorithm and you will end up with the diagnosis. And we are here because we do have a high FGF23 and also high phosphate in the urine and normal parathyroid hormone and low phosphate. And this is what's happening to our patients. So we diagnose FGF23 mediated rickets, and we send the genetic test for her, and we started her in Prosumab, which was 0.8 milligram per dose every other week, and we did the hearing assessment, part of our routine for any patient with XLH and dental assessment, and also the basal ultrasound and eye exam, and all were normal. And because of the abnormal shape of the skull, we did the CT scan and showed a sagittal cranial synostosis, which is, as we say, it's 40%. It can be seen in 40% of the patient, and this is the genetic result: heterozygous fixed mutation, and the diagnosis X-linked dominant hypophosphatemic rickets. And this is the response to therapy. This is the baseline alkaline phosphatase, and after 3 months of therapy, there's an improvement in alkaline phosphatase, which persists after 6 months, and we are here now 417, hopefully, which is a little bit higher than the normal, and the phosphate, it's improved from low phosphate to a normal, which persists over now 1 year of therapy. And it was really very safe medication, and it handled very well by the patient. And this is the X-ray. This is the baseline, and this is after almost 6 months of therapy. You may see the improvement in the bowing, and also you may see improvement in the sign of rickets. The family are happy about her condition, and also about the improvement, and about also the gait improvement and the functional improvement. And this is her picture after almost 6 months of therapy. Look at the bowing, and this is after almost 6 or 7 months of therapy. So there is a great improvement in her deformities. This is the recommended starting dose: 0.4 to 0.8 milligram per kg per dose every 2 weeks for pediatric, and for adult 1 milligram per kg every 4 weeks. And the oral phosphate and vitamin D should be stopped 1 week before you start Prosumab, and fasting phosphate should be below the reference range of normal before starting the treatment, and the fasting serum phosphate should be followed more frequently at the start than every 3 months or as appropriate. And if there is any adjustment of the Prosumab, the level has to be checked after 4 weeks. And this is what we are doing in our center for any patient before the starting dose. Usually we are admitting them in daycare for observation, and we are sending all of these basic workup, including a baseline left hand X-ray, that just as a baseline for therapy. So before I conclude, I would like to highlight these important topics as we are talking together, pediatric and adult. I think the transition of care is very important for most of the chronic disease in pediatric, and including X-linked hypophosphatemic rickets. And this was based on our survey. We found that there was no well-established transition of care in our region, and the referral usually happens as late as 18 without a clear communication with adults. So I think the transition of care should be planned earlier, and for the optimal care should be the patient should be seen in a transition clinic where there is a combined between pediatric and adult medicine. And this is one of our consensus, which has been published recently, looking at diagnosis and management of X-linked hypophosphatemic rickets. And it was an effort of our colleagues in the Gulf countries. And so in summary, XLH is one of the most frequent disease or genetic rickets, and it's a progressive disease that affecting children. It has consequences that may extend to adulthood, and children with XLH should be treated with a combined phosphate and active vitamin D as soon as diagnosis is established. And the Prosumab, this is another therapy which have an excellent short-term outcome result, and the long-term management, including early transition, is of crucial importance. And this is our team. I'd like to thank all of them for their tremendous support for the patient, all the pediatric, diabetic, and endocrine patients. And with that, I would conclude and thank you very much for your listening and for your presence. And sorry for being taken many times. Thank you very much.
Thank you so much, Fahd, for a wonderful talk. Really very impressive. Thank you so much. We'll proceed with our next speaker, an international speaker with us tonight, Dr. Elaine Murphy. Dr. Murphy has qualified from Trinity College in Dublin She's trained in chemical pathology and metabolic medicine at Imperial College, National Health Services Trust, London, and developed a specialist interest in inherited metabolic diseases. So really we're having with us tonight somebody who's really specialized in rare inherited metabolic disorders. She worked as a consultant at the Charles Dent Metabolic Unit based at the National Hospital for Neurology and Neurosurgery, Queen Square, since 2008. This unit manages over 1,400 adults with rare inherited disorders of metabolism, including phenylketonuria, glycogen storage disorders, urea cycle defects, galactosemia, fatty acid oxidation defects, paroxysmal disorders, and inherited hypophosphatemia. She's a staff at the staff in this unit are specialized in not only in the medical management but also in the dietary management of these specific inherited metabolic diseases. And this service is very specialized in the management of also lysosomal storage disorders. There are more than 60 adults with X-linked hypophosphatemic rickets attending the unit where Dr. Murphy is working, and they were part of the clinical trials that after which burosumab was approved as a therapy for these disorders. Professor Murphy is going to address us tonight on the recent update on the management of adult X-linked hypophosphatemic ricket patients. Dr. Elaine Murphy.
Thank you very much for that lovely introduction. It's nice to be speaking to you this evening. The reason we are interested in X-linked hypophosphatemia is actually because of Charles Dent. So Charles Dent developed an interest in bone mineralization in the early 1950s and established the unit here in London. So in fact, what myself and my colleague Robin Lachman are looking after, we're looking after the descendants of those original patients with XLH that Charles Dent saw. So we now have 3 to 4 generations of some families coming to see us with this X-linked condition. I have a few disclosures here. So what I'm going to talk to you this evening, I had an idea that Dr. Aljuraibah would give a very good introduction to bone physiology. So I'm not going to say any more about it because you've heard all about it already. And I'm going to go straight into the clinical phenotype in adults. And as he's already mentioned, there aren't very many papers looking in detail at the adult phenotype of XLH. A lot of the literature tends to focus on young children and the growing skeleton, but we've become more aware over recent years that this is a lifelong condition and some of the manifestations are actually much more severe in adults and accumulate with time. So there are a few papers out there from various different countries, but I'm going to spend most of my time talking about our paper, and you've seen some of the images from this already, which was put together by Doug Cheshire a few years ago. So, as mentioned, we have about 60 adults with XLH attending the unit here. So in the paper, we looked at 59 of those, 2/3 female, 1/3 male. Most of them were in their mid to late 30s at the time, but we did have individuals up to their mid 70s. And as we've already heard, the standard for these patients in adult life is to be short. So the mean height for men in our unit is 162 centimeters with the mean UK height of 175 centimeters, and for women 153 centimeters with a mean height in the UK of 161. Many of these patients are overweight. It's difficult to know whether BMI is the right way to look at them because, again, as mentioned previously, they tend to have shortened legs but a normal trunk length. But nonetheless, it's clear that many of these patients are overweight and that this might be associated with other complications as they age. 1/4 of all our adult patients are already receiving antihypertensive therapy, and actually surprisingly few were taking regular analgesia. So although they will report pain and stiffness, which is fairly universal amongst patients, they're a fairly stoic group, and very few of them are actually taking regular analgesia. They tend to save that, as they say, for their bad days. The biochemistry is as you might expect, so everybody has a low phosphate by definition. Again, as mentioned previously, alkaline phosphatase, by the time you get to adulthood, actually tends to normalize. So mean alkaline phosphatase, this is median here actually, is within the normal reference range. And again, median PTH is within the normal reference range. Although, as you can see, this is the interquartile range here. There are a number of individuals with hyperparathyroidism. We looked to see what proportion of our patients were taking active vitamin D supplementation. So for us, that will be calcitriol, and it's a significant proportion. So most of the men in adulthood were taking active vitamin D. And when we look at the phenotype, it really is quite broad and it's quite severe. So there are very few adult patients with XLH who will have gotten through life without some surgical procedure, certainly not in the past. So nearly half of our patients had at least one osteotomy in their life, usually before they come to us, so in pediatric services. A number had had guided growth or physical stapling surgery. We think that the proportion reported with osteoarthritis, hip, knee, and ankle being the most common sites is probably quite low here. The reason being that we only reported osteoarthritis in the paper if we had radiographic evidence, and we wouldn't necessarily have image joints routinely, only if patients were complaining of a specific joint causing them pain, but I think them higher than these numbers look here. And a reasonable number of patients had had joint replacements, most commonly knee or hip. None of our patients had had ankle replacement surgery, although a small number have had surgery on their ankles. And Achilles enthesiopathy is also quite common. So here's some pictures. So again, we've seen, so this is an adult woman in her 60s, and you can see very clearly the bowing of her femur here. She's had bilateral knee replacements. She's had osteotomies with tibial plating. This is another woman who's had a right hip replacement, but you can also see the very severe osteoarthritis here with narrowing of joint space and osteophytes. This is a patient in her 70s with a fracture here, a looser zone. And then this is the same patient who's had this operated on and a rod placed with intramedullary nails to treat this. And this type of surgery takes a considerable time to recover from because the healing is very slow in patients with XLH in general. And here we see some of the issues in the foot. So you can see a bony spur here at the superior posterior aspect of the calcaneus, and you can see calcification of the insertion of the Achilles. And this causes patients considerable pain and can have really major impact on their mobility, and is often the thing that limits the distance that they can walk. So very significant lower limb involvement, and this impacts on the type of jobs people can choose to do as well. Spinal complications are also very common. And again, we hadn't in the past been looking for these systematically. So I suspect there are more patients than are reported here that have ossification of the spinal ligaments, the ligamentum flavum and the posterior longitudinal ligament. But these were people who'd particularly complained of issues with their spine and so had had full spinal imaging with MRI. And you can see there's various degrees of involvement, and several patients have had surgery. So the spinal disease can be at any level. And if you operate on a patient at one level because of spinal cord compression, you may find yourself going back a year or two later to operate at another level, and again a year or two after that to operate at another level. So it's really very challenging. So this is just to show you some pictures of that. So here we see at L4, L5, very significant spinal cord compression. And then this is the same patient having been operated on and opening up of the spinal canal, so having had a laminectomy. And here's some more pictures. So you can see ossification here of the posterior longitudinal ligament, and again here. And here you see spinal cord compression again with ossification of and calcification of the ligamentum flavum. And then this patient is operated on here and has developed a complication of surgery. So they've had a CSF leak and have developed a very large pseudomeningocele. This caused quite a few symptoms, so she then required surgery to operate on that. And you can see here it's been repaired and that the pseudomeningocele has considerably reduced in size. So as patients get older, we're finding that spinal disease can be a real problem for many of them. You've heard mentioned before about dental disease, and that's a very significant number of patients, nephrocalcinosis, hearing impairment, and then we've had a small number of patients require parathyroidectomy for symptomatic tertiary hyperparathyroidism. So dental disease is particularly troubling for patients, and in fact, one of the good things of the pandemic our patients are telling us is that everybody's wearing a mask and they feel less self-conscious when they're wearing a mask because nobody can see their teeth. So the majority of our adult patients will have dental disease, and there'll often be multiple dental problems. So they'll have caries, they'll have periodontal disease, they'll have recurrent dental abscesses, which are extremely painful. Many of them will have had root canal work. They're very self-conscious about dental loss. Often the teeth cannot be saved, and so they will require dental extraction. They will have had multiple crowns and fillings. And again, as you've heard before, this is due, we think, to poorly mineralized dentine and alveolar atrophy, which again, as well as causing the condition, also makes putting in a dental implant extremely challenging. And patients will struggle if the dentist doesn't know anything about XLH, because they'll often be accused of poor dental hygiene, whereas that is in fact obviously not the case. And so it's very important that these patients have lifelong appropriate dental care. And again, just to show you some of those pictures in more detail. So here you can see an abscess in an upper right molar. This patient also has a crown. They've also had multiple root canal fillings. Here you can see the discoloration of the front incisors, upper and lower, again related to multiple abscesses and infection with time. There's dental loss here. In this picture, the same patient has had a dental bridge put in, which is cosmetically very good. And again, you see the same here. You see multiple fillings, and you see the abnormal pulp chamber and a small abscess here. So dental disease, very painful and very common. We wondered about renal function in our patients, but in fact, in the majority of patients, although we see quite a lot of nephrocalcinosis, you see a similar age-related decline in EGFR as you do in the general population. And we only saw one patient with an EGFR below 60. And this was a man who came from a family with extremely severe form of XLH. And in fact, all those pictures I've shown you of the spinal disease, and the first picture that I showed you of the with the bilateral knee replacements, all those individuals are from the same family, and they have a particularly severe mutation, and both men and women are very severely affected. But other than that, we don't seem to be seeing much decline in renal function with age, despite nephrocalcinosis. We spoke about hearing impairment, and again, I don't think this has really been looked at systematically very well. Again, before we put our paper together, we hadn't really been assessing hearing systematically in all our patients. We've begun to do that a bit better now, but this is one particular paper where they did look at 20 adults and also 6 children, and a significant proportion of those had hearing impairment, and that hearing impairment is often associated with tinnitus, and our patients will often report dizziness or vertigo as well. And the cause of the hearing impairment, or the pathogenesis of the hearing impairment, it seems to be a mixed picture. So you do get some conductive loss, but also many patients have sensory neural hearing loss as well. We wanted to look at pregnancy because we had seen that quite a number of our women with XLH had delivered their children by cesarean section. So of the 34 pregnancies to women that we looked at, 3/4 of them, of those children, were delivered by cesarean section, and that's a much higher rate than in the UK general population, which already has a high rate of cesarean section at around 27%. In the Danish paper, looking at adults with XLH, they found a much lower rate of cesarean section. A large number of individuals in this paper came from a single family, so it's possible that they didn't have such a severe XLH mutation. In New Zealand, they had a similarly high rate of cesarean section as us, and then there's a very small paper from the USA with just 9 women, and they didn't have any women give birth by cesarean section. So there are various reasons. We think that some of it is obstetricians being a little nervous about increased risk of complications in women who are short and who may have an abnormal pelvis or involvement of their hips. But it's certainly women can give birth vaginally, but there does seem to be a suggestion of an increased rate of cesarean section. So having given you some idea of the broadness of the phenotype and how severe the phenotype is in adults, I'll just go on now to talk about in a little bit more detail about burosumab itself, first looking at the literature and then just showing you a little bit of data from our own patients here. So we've heard a bit about burosumab in children, and following the pediatric trials, there were also a small number of papers with open label or trial extension studies in a small number of adults. I've just listed these here, but I won't get these two papers. So the randomized double-blind placebo-controlled type of burosumab in adults, and then the longer-term treatment continuation trial in the same group of adults. So the initial publication from 2018 was of a 24-week randomized control trial in adults aged 18 to 65 years, all of whom had a confirmed FEX variant. An inclusion criteria into this, as well as having a FEX variant, was that you had to have a brief pain inventory worst pain score of greater than 4, and the scale there goes from 0 to 10. So if you had very minimal pain, you couldn't enter this study. There were a number of exclusion criteria. So if you had significant hypercalcemia or hyperparathyroidism, and if you've had recent fracture or orthopedic surgery, you also couldn't enter the study. And before starting the study, you had to have a 2-week washout period if you were taking phosphate and active vitamin D analogues. And there was no, every adult in the study was given the same dose of burosumab, so everybody was started on 1 milligram per kilogram or placebo subcutaneously. And in adults, it's not given every 2 weeks, it's given every 4 weeks. And these are the baseline characteristics of the participants. So roughly the same number of individuals in the placebo and the burosumab treated groups. They were in their late 30s to early 40s mean age, going up to mid 60s. About 44% were female. Majority of patients were white, but there was a number of Asian and a small number of Black participants. Most had had at some point in their lives conventional treatment, so with phosphate and vitamin D, as we'd heard previously. And again, not surprisingly, most had had orthopedic surgery in the past. So they're a good representation, I would say, of our current adult patients with XLH. And as we saw in the children, burosumab increased serum phosphate and increased the tubular resorption of phosphate. So we have 2 lines here. In red are the placebo-treated group, and in blue are the burosumab treated group of adults, and this is serum phosphate here, so you see it very quickly, and here in the dotted line is the normal, the lower limit of the normal reference range, and you can see very quickly with the first dose phosphate rises to within the normal reference range, and it stayed there for the duration of treatment, the 24 weeks. And this is at the midpoint of dosing, so 2 weeks after a dose, and this is at what you might call the trough point, so just before the next dose is given. And again, similarly with tubular resorption of phosphate, it increases immediately after the first dose and remains elevated in the excuse me, the burosumab treated group for the duration of the 24-week study. And this is serum 125 dihydroxyvitamin D, which is activated and again increases in the burosumab treated group. If we look at clinical outcomes then, and again, we're looking, red is the placebo treated group and blue is the burosumab treated group. And these are scores. So the higher the score, any treatment we've been using before for XLH. So the most common adverse events were back pain, tooth abscesses, which we think are probably just the underlying disease, headaches, dizziness, pain in extremities, and injection site reactions. And we'll talk a little bit more detail about those when we come to look at our own patients in the unit here. One interesting one that popped up was restless leg syndrome, and you can see there are a higher number of patients treated with burosumab who reported restless leg syndrome. Very few with hyperphosphatemia, nobody with ectopic mineralization, and nobody needed to discontinue because of an adverse event, and there were no deaths. So following that initial 24-week study, those patients were then offered an open label burosumab. So all patients, whether they'd been on placebo initially or burosumab initially, were then converted to burosumab 1 milligram per kilo with a maximum of 90 milligrams per patient. So of the 134 individuals who did the first 24-week study, 133 of those opted to enter the open label study, and 126 of them completed the 48-week study. And this is just showing you that there. So you end up with two groups at the end of this. There's a group who had burosumab from the beginning, so 24 weeks plus another 24 weeks. So they're the burosumab group. And then there's a group who started off on placebo for 24 weeks and then were converted to burosumab at a similar dose. And they're the placebo burosumab group. And the majority of patients continued through to the end of the study. And this is just showing you similar data to what we've seen before. So this is looking at fracture healing. So you'll remember that number, 7.7%. So that was a small number of patients who were on placebo, who'd healed their fracture at the end of 24 weeks. But when they were converted to burosumab, this increased up to 35%. So it was approaching the 43% that we saw in the group that were treated with burosumab from the start. And interestingly, that group who continued with burosumab, you had an increase in fracture healing for the remainder of the study, so that by the end of the 48 weeks, 63% of that group had healed fractures. And again, similar data with regard to the WOMAC stiffness score continued to come down in both groups. So actually by 48 weeks, it was similar in both groups. And here we've got placebo in black and burosumab treated in blue. And this is the physical function score. Again, they are very similar at the end of 48 weeks. And this is the BPI, the worst pain score. And again, improving in both groups by 48 weeks. Along with that, you see an increase in the distance that patients could walk. So they did a 6-minute walk test to see how many meters they could walk in that time. And again, by the end of the 48 weeks, both groups had reached a similar distance. So in that extended study, no new safety concerns were noted. So there were no additional new side effects or adverse events that hadn't appeared in the first 24-week study. There were actually 2 pregnancies in this time. So one was during the treatment continuation phase, so the second group of 24 weeks, and one was actually after the treatment had finished completely and the patients were offered the open label extension phase. Both of those women gave birth to healthy term babies. And what about burosumab in our own units? So that's the world of clinical trials, and often, sometimes what you see in the real world, you don't get similar results. So we have been fortunate enough to have access to burosumab in our unit as part of an early access program in the UK. So a small number of pediatric and adult centres in the UK that see patients with XLH can apply for early access to burosumab before it is hopefully fully funded by the NHS. So all our adults start, as in the clinical trials, on burosumab 1 milligram per kilogram given monthly. We give the first dose in hospital, but then the subsequent doses are given in the patient's home by a home care nursing team. We do all their baseline assessments in hospital before their first dose, and then we do the follow-up blood tests are organised again by a home care nursing team who sent. We started this program just as the pandemic was taking off in the UK early in 2020. So it has been challenging, but we have managed to get a few patients treated over the last year. So the eligibility criteria were, of course, that you had to have XLH, so you had to have a fixed variant. You had to be above the age of 18. We don't have any upper age limit for the early access program. And then these are the criteria. So you have to have at least one of these. You have to have moderate to severe pain, stiffness, and or fatigue, which impacts on your quality of life. And that is physician assessed. Patients have to have a non-healing or slow healing fracture or pseudo fracture, or they have to have undergone or to be about to require orthopedic surgery, dental surgery with bone involvement, or spinal surgery. And if so, we will give them treatment for a defined period, which is usually 3 months pre-surgery, if the surgery is planned, or 6 months post-surgery until we judge that the wound has healed. So actually, we've got fairly generous entry criteria, and most of our patients would fall into one or other of these categories. There are a small number of exclusion criteria. So obviously you've got to have XLH, so you can't have non-XLH hyperphosphatemia. If you've got known hypersensitivity to any of the active ingredients of burosumab, all patients must stop oral phosphate and activated vitamin D analogues before treatment. If you start with hyperphosphatemia, you cannot be given burosumab. And if you've got severe renal impairment or end-stage renal disease, then burosumab is not offered either. So this is how we follow the patients, and we, broadly speaking, we've opted to follow the clinical trial program as much as we can. So everybody at baseline has weight, fasting phosphate, basic kidney and bone bloods done, a renal ultrasound, a bone scan. We ask for a timed up and go test. So sit down, stand up, walk 3 meters, turn around, walk back again, sit down again, and that's timed. A 6-minute walk test to see how far individuals can walk. They fill in a number of quality of life questionnaires. We ask them about surgery at various time points, and we ask them about adverse events. And we do the first fasting phosphate at 2 weeks, and then we make adjustments then. So far, we've managed to start 31 patients on this program, 19 of them female, 12 of them male. Again, like we've seen before, many of these patients are overweight, but we do cap the dose at 90 milligrams per in total. They have hypophosphatemia at baseline, and this is the 2-week phosphate. You can see it's already come within the normal reference range. Alkaline phosphatase was close to normal. PTH in this group was actually slightly higher baseline, so it was just outside our normal reference range. They do have a prolonged timed up and go, so for a completely normal mobile person, you would expect them to be able to do the timed up and go test in less than 10 seconds. And once you get above that, you have slight impairment, and the longer you take, obviously, the more impairment you have. And again, they have impaired 6-minute walk tests. So again, you would be expecting a completely normal young person up to their 40s to be able to do roughly 600 meters or more in 6 minutes. So you can see their baseline 6-minute walk test is quite reduced. And in 30 out of 31 patients, serum phosphate increased in the normal reference interval within 2 weeks, so it is very rapid. So just looking in more detail at the 6-minute walk test to give you an idea of the severity of the patients that we're treating in adulthood. So the group as a whole walked 311 as opposed to around 600, which is what we would have expected. 14 of them walked less than 400 meters. Only 10 were able to walk between 400 and 700 meters. And we actually had 7 patients who couldn't actually walk for a full 6 minutes. All of these individuals were older than 50, and all of them required at least one mobility aid, and they simply had to stop due to either significant fatigue or pain, and they couldn't walk for 6 minutes. We're looking at the WOMAC. So with the 3 WOMAC sections: pain, stiffness, and function. And in these, a higher score is worse, a lower score is better. So a score of 0 means you've got no pain at all, or no stiffness at all, or no impairment of your function. So you can see actually very similar between the hip and knee, and all patients have got significant pain, stiffness, and impairment of function, physical function. We looked at their quality of life. Here for the overall health scores given by the patient, and in this situation, a higher score is better health, but the score is out of 100, so effectively they're giving themselves quite a low score at down around 56 for their overall health. And here with regard to mobility, self-care, usual activities, pain, discomfort, anxiety, and depression, a higher score is a worse score, and you can see the impact on these various aspects of their lives.
5 minutes, Dr. Murphy, 5 minutes.
Just finished. So adverse events, very similar to what we saw in the papers, but it was interesting to look at this in more detail. So if you were starting, in particular your adult patients on burosumab, about 60% of them will initially report a worsening of pain. And this is quite interesting because it's rather non-specific. It's not necessarily, as far as we can see, in the joint that you think they have worse disease in. Quite a number of them mention lower back pain, but it can be in other areas as well. But we definitely see that usually up until the second dose, and then it starts to improve. Restless legs has been quite common and can be quite disturbing for some patients, and we've treated 2 patients with gabapentin, which has helped. Again, it seems to improve by around the time of the second or third injection. Insomnia has been described. A number of our patients reported dizziness, and again, as with almost any new treatment, headaches are reported. So one of our 31 patients discontinued treatment actually because of insomnia. So she tried a number of things, including sleeping tablets, just didn't work, and she opted to discontinue treatment. So to finish off, I think it's very clear, hopefully to everyone by now, that adults living with XLH have this significant disease burden. They have orthopedic involvement, spinal involvement, dental involvement, hearing impairment. A number of them will require a parathyroidectomy, and they potentially have secondary issues because as they get older, they gain weight, they have reduced mobility, many of them have hypertension, so we would certainly be concerned about their cardiovascular risk. I think we've shown clearly as well that treatment with burosumab can normalize serum phosphate, it can heal fractures and pseudofractures, and it can improve the scores for pain, stiffness, and physical functioning, even in adults. There are a number of unanswered questions, so we don't yet know the effect of burosumab on the incidence or course of enthesopathy. We simply don't have a follow-up for a long time. We have very little evidence about its impact on dental disease. Again, very little that we can say about nephrocalcinosis. And we are a little bit concerned about long-term risks of pathological calcification and ectopic calcifications, such as with coronary arteries, and we don't have any data on that as yet. So I'd just like to finish by thanking Dr. Gauri Krishna and our clinical nurse specialists who do most of the work with regard to the adult patients with XLH here, and Doug Cheshire, who as you've seen, collected much of the data for our paper. And thank you for inviting me. I'm happy to answer questions.
Thank you so much. Lovely presentation, Dr. Murphy, very educational and informative. May I ask Fahd to join us in the Q&A sessions? We have some questions here. So Nasser Al-Qahtani is asking, how common is this disease in Gulf area?
Thank you very much for this question. I think the problem is we don't have clear data in our region, but we believe that we do have quite a good number of patients. And to estimate the prevalence of the disease, we started with the help of the COIA current to establish a registry, not only for the XLH, but for all FGF23 mediated rickets. It goes live. It went, I think, live I think in the last 3 months, we start to recruit patients in the whole region of the Gulf region. So aiming to estimate the prevalence and the incidence also of the disease. And the aim is also to look at the long-term outcome of this rare disease. But we don't have a clear, but I think we are in the stage of collecting this data.
Wonderful. How common is this disease in Europe, Dr. Murphy?
That is a good question. And as you were talking, I was trying to look up. So we're doing the same. We're trying to estimate, because we also don't have good data. So we are trying to estimate the prevalence. And we have been putting some stuff together for a poster. And maybe move to the next question while I look through the poster and try and find that number for you,
right, okay.
Which I should be able to get in a second.
Sure. Now, I think you answered this question. Is there any study on adult X-linked hypophosphatemic rickets treated with burosumab? Do they benefit from this therapy? The answer is yes, if initiated in adult age in terms of deformity and quality of life. That question has been answered. And also you alluded to the unanswered questions in this age group. Now, this is a clinical question. Attendee's name is not there. An adult female in late 30 with X-linked hypophosphatemia started on burosumab. Question 1, during follow-up, phosphate remained low normal despite dose increase. What do you do next? So 30 years old, started in Borusumab. The person who's answering the question that the dose was increased, no mention of what the dose that has been reached. But the phosphate remains low normal. PTH was getting high with normal vitamin D above 50 and normal adjusted calcium. Any advice?
So, you want me?
Yes, Fahd, go ahead.
No, and I think this is one of the tricky questions. Sometimes it depends on the severity of the disease. So, and I've been consulted from Bahrain for one patient who's I think she was almost 18 years, and she was having a picture of I think TIO, which was a tumor in induced osteomalacia, where they do have an FGF23. So she was having really severe hypophosphatemia. We started
Fahd,
her on.
Fahd, can you make your voice louder, please?
Right. When I go in now, I do have some, and I remember that I've been consulted by one of my colleagues in Bahrain, where they do have patient with the TIO, which is a tumor-induced osteomalacia, which is also the same FGF23 mediated rickets, and she was having very, very low phosphate level. So we started her on the adult dose, and she took time. She took time to for her phosphate to be corrected. I think this is because of the severity and the long-standing hypophosphatemia. I think she needs time. The other points that you need to they have to give her the maximum dose, not exceeding the maximum dose. And I remember that it's 80 milligram, the maximum dose that shouldn't be exceeded, and it should be 1 milligram per kg every 4 weeks. And the other things that the vitamin D and also the parathyroid hormone should be normalized. If she has a problem in the calcium intake, vitamin D also has to be corrected, because also the parathyroid hormone, it will lead to hypophosphatemia. I think it could help.
Okay, Elaine, any addition?
I don't think so. I've not seen it, so all of ours have normalized. So I think you might be right, Fahd, that perhaps it's either there might be low vitamin D, just 25 hydroxyvitamin D, or that it's another cause, or that the dose isn't quite enough and they haven't given the maximum dose. So I have to say quite a number of our patients require the maximum dose, which for us is 90. So a number of them are on that top dose, and maybe you just need to wait. Although the majority hit normal phosphate with the first dose, maybe it's just a bit of time. I have to say I haven't seen it.
All right. Question to either of you: at what time patient can have a safe corrective orthopedic surgery after receiving Borusumab? So you started now. The surgeon wants to do some correction for whatever deformity. When can you allow that?
I think it's like going to be most of the questions that are asked by people who already know quite a lot. I'm not sure that we have a precise answer for it. So we would prefer to start a few months before, so that if you've got other areas of the bone to heal, if they've got little pseudo fractures, that you've got some Borusumab on board, also so that you know the correct dose, so that you know that you've had a chance to normalize the biochemistry as best you can. So I think we would prefer to start, at least 8 weeks before surgery if we could. But I have to say, realistically, we have started 2 weeks before surgery because somebody was about to have major surgery. We thought it would be better to have some rather than none. But I don't think I know the precise answer to that. I do know the precise answer to how many people have XLH in the UK, though. I've just found that out.
Okay. All right. You can tell us. You said you have an answer. How many people in UK? Elaine?
We with the best survey that we could do, we found 352 individuals with XLH. That's out of a population of 56 million. So it's not common.
Okay.
Somebody would need to do the maths to work out what the one in whatever, but 352 out of 56 million.
Wonderful. Okay. I think we have more than 510 attendees, and really they are asking tough questions. So let me give you another tough question. What's the physiology of lowering the alkaline phosphatase in these patients after brusumab? Why does it go down?
So I think the concept is almost completely the same with the conventional therapy. So what we are trying to do is to normalize the phosphate that will lead to improvement in the Rickets marker, which is the alkaline phosphatase. So by giving brusumab, you are improving the phosphate. So that would lead to the improvement in alkaline phosphatase, and this is the marker that you should follow, that it would indicate an improvement in the clinical manifestation or in the Rickets biochemical manifestation at least.
So healing of Rickets.
Yeah.
And I suppose to go along with that, in adults where if you don't have pseudofractures or you don't have very active bone disease, you often don't see that much of a change in alkaline phosphatase. So often we're starting with a fairly normal alkaline phosphatase. So it's not such a good marker for that in an adult, but obviously in a growing child, it's quite different.
Okay, what about using cinacalcet, hydrochlorothiazide, and the vitamin D analog paricalcitol?
So I have no experience because we haven't used it, but I know, of course, that it has been used, and it has been used to, it may allow you to use lower doses of phosphate and active vitamin D. So sort of pre-brusumab, it was another arm of treatment that you can use. We didn't have easy access to it for that use in the UK, so I don't have much experience. I don't know, Fahd, if you have used it much.
Okay, even me, and I'm not in favor of using the cinacalcet, especially in a young patients, because it's not approved even for pediatric, and there is a case report of sudden death of using cinacalcet in case of hyperparathyroidism, including in different causes. So I'm not with the cinacalcet, and we don't have صراحة an experience in using it, and it's not actually really recommended to be used.
Paricalcitol?
Paricalcitol, and is it if you meant the active vitamin D? Yes, it is used with the phosphate as a conventional therapy. Yeah.
I think it's very important to point out, which Fahd did, how challenging the conventional therapy is for patients to take. So nobody will take phosphate 4 times a day. They can't remember it. It doesn't taste nice. It causes loose stools and diarrhea. So people find taking the conventional therapy in the correct way extremely challenging. So I think that's why in the past we also had lots of complications like tertiary hyperparathyroidism because of people taking treatments incorrectly.
Yeah. Any difference between 1-alpha and calcitriol? There is a question about that. You can give either, isn't it?
Price.
Okay.
Price.
Yeah. Calcitriol, it's really expensive compared to the 1-alpha, but it is. I think there is no big difference.
Yeah. Okay. Why do they develop dental abscesses, Elaine? Why they have abscesses so common?
So the dentine is very poorly mineralized. Mm-hmm. I'm not a dentist, but the dentine is very poorly mineralized. So I think the protective layer between the tooth and the pulp is missing. They also have quite a lot of alveolar recession around the gums. I think you could see that there. And again, that allows access of microorganisms. And I think it's very hard to keep that area. Once you get a microorganism in there, it's very hard to clear it. So I think that's the main thing. It's a very poorly mineralized dentine. So people with other disorders where they have poorly mineralized dentine also have an issue with dental caries.
Somebody's asking,
and the shape of the tooth is...
Yes?
The shape of the tooth is abnormal as well. And I again, without being a dentist, I think that probably makes them more susceptible to infections also.
Okay. Is there somebody's asking, I'm not sure if this is relevant, any association XLH and carbonic anhydrase deficiency?
What I know,
there's
Fahd?
No, go ahead.
I'm not going to say very much. I'm going to say I know phosphate has some impact on carbonic anhydrase activity, but I don't know if anything specific. Do you find?
I think what I know that the carbonic anhydrase, if there is a problem with the carbonic anhydrase, this will lead to osteopetrosis, where there will be a high bone mass that will lead also to proximal tubulopathy. So the carbonic anhydrase are involved in the bicarb absorption in the proximal renal tubules. If there is a problem with the carbonic anhydrase, those patients usually they will have osteopetrosis because also it's involved in the osteoclastogenesis or the osteoclast function. So they do have a problem in the osteoclastogenesis. So they will have an increased bone mass, which is an osteopetrosis, and also because they're involved in the proximal renal tubules, it may lead to proximal tubulopathy and some sort of hypophosphatemia, which is completely different from X-linked hypophosphatemic rickets.
Okay, great. Why do you have to discontinue calcium and vitamin D supplementation before burosumab administration?
You've got to continue phosphate, not so phosphate and vitamin D beforehand. You'll get hyperphosphatemia if you don't. So once you start treating with burosumab, because as you've seen how effective it is of pushing the phosphate back into the normal reference range.
Discontinue phosphate, not calcium.
Yeah, they're not on calcium in general. They're on phosphate and vitamin D. I think that was probably just a typing thing.
There are some lots of people who are really saying thank you so much. Great presentation from various regions. Here is somebody, Rawia from Egypt. Thank you so much for attending. Attendance was really great. Questions were really excellent. And I think I would like to say that one thing about you have this program in UK, Elaine, but it's good to say that in KSA in the Kingdom, it has been approved by the Saudi Food and Drug Administration for children and adults. So children above 1 year, Fahd, isn't it?
Yeah, just recently approved for more than 1 year.
Okay, here is a tough question. Cost of burosumab.
This is the most side effect of burosumab.
Okay.
But looking at in the bigger picture, looking at the cost effective medication,
yes,
I think hopefully in the long term it will improve the outcome and it will be cost effective.
Absolutely. Just before concluding, any comments, Elaine, and then Fahd? There is thank you. Somebody from Tunisia.
I think it is going to be a challenging.
Elaine, let me say this. Somebody from Tunisia is pressing to say thank you so much for a good presentation. Please go ahead.
I think the cost will be a challenge. I think when we're assessing it, we're going to need to look at the lifelong cost of these patients. So all their joint replacements, the fact that they have to stop work early, all of that's going to need to be countered against the cost of burosumab, which is what is happening at the moment in the UK. So the NHS is looking at that, and we'll be looking at, well, what is the financial cost of that, and weighing it up. I just saw one other quick question, which is, does the dental disease heal up with burosumab? And we're really interested to know that, because that is actually very significant impact on people's lives. I don't have that data yet, but that will be very, we would assume that if it's a similar mechanism, that we will see improved dental health in these patients in years to come. But just as yet, we don't have the evidence for that.
Fahd?
I would like to thank you, kindly to thank GAED for this, for organizing this wonderful webinar, and I'm really happy and glad to join Dr. Murphy in this also webinar. And the things that I would like to highlight, it's really a progressive disorder, XLH, and actually we are in the learning curve of the new medication, and many things need to be answered in the future. We need to collect that data, including the outcome, the orthopedic outcome, dental outcome, the renal outcome, and many outcome in the adults that need to be answered. So we are in the collecting or the learning curve actually. I think a lot of things need to be done, inshallah, in the future to answer many questions.
Wonderful. Thank you so much. At the end, before concluding, I would like to thank you all the attendees. The more than 510 people were with us tonight from various countries, not only from the Gulf region, but I can see people from Libya, from Tunisia, from Egypt, and many other countries, Pakistan. This is really great. A great session, great attendance, excellent, very informative presentations by Elaine Murphy from UK, Fahd Aljuraibah from Saudi Arabia. Thank you so much. I would like to thank the board of directors, my colleagues in the board, Dr. Ali Ma'mari and his group, and the webinar committee, Rafat Husni and colleagues from Amber who took the arrangement, the technical aspect of the meeting. Really the big thank comes to the great audience who were with us, who asked really also tough questions. I do thank you for being with us late tonight. Elaine Murphy from UK, thank you so much. We know the difference in timing, and everybody is tired after a long working day, but yet you elected to join us in this meeting. Thank you very much, and please, as I mentioned, log into our webpage, GAED, GAED.info, and see our activities, previous activities, people practicing endocrine, diabetes, family medicine, internal medicine, the Gulf countries can register and become a member of GAED freely this year. So next year we'll ask you to pay money, but this year it's free. Join us in our webinars, our various activities, our board review course, our lipid disorders symposium or course, our osteoporosis course. Excellent activities, various disciplines of endocrine are covered. So please join us in these activities, and don't forget also to spare your time for our big meeting in October, our annual Congress, with almost 56 presentations and more than 20 international speakers and other regional Gulf and Middle East speakers. Thank you so much and have a great night.